Hello all and welcome to today's tele-echo session. Today will be the physician clinic session and tomorrow we'll be having our QI clinic. As a reminder, we will be due now is all of our baseline data as well as our October and November data. Our next case presentation will be due December 10th and our next echo clinic session will be December 17th and our QI clinic session will be December 18th. I would like to welcome everybody for coming today. I apologize, Michael will not be in attendance today, but I will be filling in. As our moderator for the day. So just some housekeeping items before we move forward. We would like to thank you and we value and appreciate all of your participation. For educational and quality improvement purposes, this tele-echo session will be recorded. By participating in this session, you are consenting to be recorded, and to protect patient privacy, please do not provide any PHI information. If you have any questions at the end of this presentation, please email jake@jsafmary@njaap.org. Please mute your microphone when not speaking within the session. This can be found on your computer via the icon located at the lower left or top of your screen. If you're logged in via telephone, please press *6 to mute and unmute yourself. When communicating, please speak clearly throughout the session, and please use the chat function to send any messages to NJIN at NJAAP if you have any questions throughout. Please do not put your phone on hold. If you must leave the meeting, we will hear the hold music. So just as a roll call before we begin, Virtua Mansfield, do we have anybody on from Virtua? Okay. Capital Health Internal Medicine Residency, do we have anybody on the call from Capital Health? Freehold Family Health Center, is anybody on from Freehold? Okay. Palisades Hospital? All right. Happy Healthy You Family Medicine? Okay. Robert Wood Johnson Medical Associates? All right. And St. Francis Medical Center? Well, it seems like we have a quiet bunch. I do see several of you logged into today's call, so I do know you are here. I just don't know which of your teams you're a part of, so I will make sure I send a follow-up email afterwards to see if we can get that clarified. So for the accreditation today, each physician and clinician must complete the evaluation to receive credit. You will be receiving an email by close of business today with a link to the evaluation. And below are the following disclosures. These are all the individuals that were involved in the development of today's presentation for your records. I would now like to introduce our two speakers for today, Dr. Cindy M. Barter and Fran Griffin. Dr. Barter attended the University of Kansas Medical School, where she received her Doctor of Medicine. She completed her residency at DeWitt Army Community Hospital in Fort Belvoir, Virginia. Since 2009, she has been on the faculty for the Hunterdon Family Medicine Residency Program. She directs patient care at Hunterdon Family Medicine at Phillips Barber and is responsible for providing and teaching maternity care and inpatient family medicine rotations. Fran Griffin has worked in healthcare for over 30 years, particularly in areas of quality improvement, patient safety, and innovation. Ms. Griffin is a registered respiratory therapist and faculty at the Institute for Healthcare Improvement, where she worked for 8 years. Previously, she worked at the CMS Innovation Center and several health systems in New Jersey. Fran works with NJAFP and other organizations on clinical QI programs and is the author of numerous articles related to patient safety and quality improvement in healthcare. And now I would like to turn it over to Dr. Barter.
So let's see. I don't know that I have control over, there we go. Now I have control of the screen, I think. Mm-hmm. So anyway, we're going to talk about improving flu vaccine rates today. So Jake, I'm not able to advance the slides.
Left click on your mouse one time. Oh.
Nope.
Try one more time.
Okay.
One more time.
There we go. Okay. So first, start out with a question, and Jake, if you've got this, so people can pick all that apply. Of which of the following tactics can improve flu vaccination rates in your office?
Your family, and Capital Health is here to help you prepare, whether it's maternity tours for expecting parents, discussion groups for new.
Sorry about that, everyone.
Hopefully everybody's been able to pick their choices. Okay. So we're going to move on and discuss some of these. So Jake, I think you need to give me control back again.
Click on your left mouse one more time. Oh.
Yeah, for some reason that sends it out of the main slide presentation, but I'll try it again. There we go. Okay, so we have a case for today. A 55-year-old African-American male with diabetes comes for routine diabetes follow-up. The MA on rooming the patient asks if he wants the flu shot, and he says no. So my question for you is, in your office, do you know how that question is asked? Do you have any training of your MAs, particularly focusing around the flu vaccine? And it's okay to say, no, you don't know, or you don't have any specific training for it. So I don't know if you need to unmute if you're going to provide a response. No specific training currently. Okay, so is there any past history that you would be helpful to know about this gentleman as he's in your office in regards to flu vaccines or other vaccines? So we have a response that they refer to the physician to handle if patient refuses. And Dr. Camille from Virtua, so somebody else is listening in for the practice. That's great. And so one of the things we need to think about is what does happen in the office, and never vaxxer of any kind, so he's never received any vaccines, and he's been coming to your practice for a while. Is he new to the practice, or is he somebody that has gotten in the past and just has not gotten this year? It may be his daughter's getting married this weekend and he just doesn't want it right now, but he's willing to set up a time. So trying to figure out when that response is no, what's the next step? All right, so the next slide should advance. There we go. So one of the things we're thinking about looking at the communication with the MAs is, can we ask it in a very encouraging opt-out language? Like, the doctor would like for you to have the flu shot is very different than, you don't want a flu shot today, do you? And so really having that empowering the MAs, often in a lot of practices, particularly when we're looking at healthcare disparities, the physicians, there's a lot more white physicians in the United States than there are physicians of color, but often the MAs are people that are from the local community, and whether that's of, certain ethnic or racial groups, but sometimes they have more of the relationship with the patient, and there's also not that power differential of, patients don't want to say no to the doctor, but they might explain to the MA about what their concerns are. So sometimes, thinking in your office, can you have any training about the next question of, do you mind sharing your concerns with me, or tell me what you've heard about flu vaccines? So that way you can start the discussion. And, is there communication between the MA and the physician, either in the electronic health record or on paper, before the provider goes in to have that information available to them? So when we look at racial disparities, just flu vaccines, in only 41% of adults tend to get the vaccines. When you're looking across the United States, about 60% of kids do. So we definitely are not meeting the goal of trying to get flu vaccines to everybody. And then when you look at racial disparities, the African Americans tend to be 37% vaccinated, we're only, and 45 of white Americans. And when you study African Americans, they do say that public health guidelines and a relationship with their provider can make a huge difference on it. So, when you look at the 28% says it's important, 24% fairly important, and 16% extremely important, that means we can really make a difference. And so we know that patients may not completely trust the healthcare system, but if they have a trust in their own physician and the physicians make that recommendation, then they're much more likely to get the vaccine. And so one of the things, looking at where does that trust come from? If patients have a sense of racial fairness, they're much more likely to have a higher trust that the vaccine is effective, that the perceived risks are low. If they have a racial consciousness that there is a difference of race in how they're treated or experience of discrimination, then they're much more likely to have a lower trust level in the vaccine, greater perceived risk of the bias on that. So those may not be something that MA is asking about, but it may be something we need to be aware of in our practice as we're trying to assess, what's some of the reasons that they're not willing to get the vaccine. Okay. Sometimes having materials which you can get from the CDC that are based on your cohort of patients, ethnically, racially sensitive, with pictures that people recognize. We know a lot in the African American community from studies that have done looking at flu vaccines. If it's something family members recommend, or if they see somebody that has had it, they're much more likely to get the flu vaccine. And so we also need to think about in our office what percentage of our healthcare workers have actually gotten the flu vaccine. Some healthcare institution it's required, some it's not. And sometimes that message that the MA gives, sort of like, you don't really want the flu vaccine, can make a big difference. Do that, again, in our office, we can really look at what's called ask, tell, ask. So like, for example, I understand you don't want the flu shot today. Can you help me understand your concerns? Do you mind if I share with some information with you about the vaccine? So asking for their permission tends, and most patients, if you ask that, don't usually say, no, don't share the information with me unless they're on a completely different agenda. And so usually people respond if you ask it in a respectful way, and then give them the information that they're concerned about. So we do find that African Americans tend to be higher level of concern about the side effects of the vaccine. And then ask again, so what are your thoughts about it after you've had that discussion with them? We need to respect their autonomy if they say, no, they don't want it. And it may be that they don't want it today, but they'll be willing to get it, in another visit next month. So again, trying to figure out, what some of their concerns may be can make a big difference on the next part of the discussion. So some of these, again, most flu vaccine campaigns focus on the risk of the disease and not so much the risks of the vaccine. And that's something that I think that we need to look at. So something you might say is, we know that flu vaccine is approved annually and safe with only minor side effects. few people get, the reason that's important that with your diabetes, you are more likely to have serious side complications from the flu, and I strongly recommend that you get the vaccine. Or as your physician, I recommend that you consider getting the flu vaccine. Just saying that can make a big difference on people actually getting the vaccine. So in our offices, some of the things that we know makes a difference, and find a champion. So does that champion have to be a doctor? Not necessarily. I find it's really helpful if you can have more than one person, so having a team. I know we talked about last time having standing orders. Do any of you have standing orders in your office for the flu vaccine? Great, so we've got at least one office that does. And so, with that, really trying to look at, are you documenting where it's given? Do you have a place to document if it's given in another location? What about if there's a severe reaction? What if there's some kind of system shortage? This year so far, we haven't had any evidence of that, but some years that's been a real issue. So somebody may be willing to get it, but just didn't get it that visit because it wasn't available. And then do you have a place to document if they decline? I know in our office, we've done some different studies comparing different offices that they had to sign a refusal sheet, or they just signed an information sheet about the flu, and we compared different offices, and those that actually said, I understand the risk and I am declining the flu vaccine today, we had more uptake of the flu vaccine. And so those examples will be available, I think, Angie, on the QI. Angie, can you help out where they'll be, that folks can look at those examples?
Sorry, couldn't find my mute button. They'll be up on the Simple QI website.
So then if, again, not that you have to use those, but if you want to look at those for examples. Again, when you're optimizing your documentation, we don't need to, you'll have a place to record if they get the flu vaccine, but really looking at when they're saying no and how do you have that conversation with them. I'd like to get your perspective on ER pop-up reminders. Are those helpful or not helpful? I know in our office, sometimes we can get sort of reminder fatigue in the EHR. Exactly, that alert overload. And so sometimes looking at a different format, and you can never overdo individual person-to-person communication. And so kind of going back to the old-fashioned way, the MA talks to the doc and says, some offices have looked at, brightly colored reminder sheets, or, something else that is, part of the visit that can remind people to have the discussion about the flu shot. We do know given feedback makes a difference, and how do you create healthy competition? Is it between provider to provider? Can you create teams of how are you doing? I know our 2 residency offices have competitions for flu vaccines, and it becomes quite fun, but by the same token, it also gets people really thinking about it on a more regular basis. A couple good articles, How to Talk to Reluctant Patients About the Flu Shot, and Back to Basics, 5 Steps to Better Understand Influenza Vaccination Rates. And again, there's the resources that we had last week about standing orders that, it sounds like more people in the group have standing orders for flu vaccines, but last week it didn't sound there was a lot of standing orders for some of the other vaccines. Okay, Fran, I think.
Yes, okay, great. Thanks, Cindy. And let's hope that advancing the slides works now that I've got control. So as you think about what might you change in your own practice if you don't have a standing order, for example, using one, or a form like Cindy, you were just mentioning, for people who decline so that you capture that information. I would encourage you that any change idea you come up with, that you test it first. This is all part of using the model for improvement that many of you are already familiar with. So why do we test? So there are a variety of reasons to test first. I'm sure everybody can think of an example of some time when you were working either in your current practice or someplace else where somebody came up with what they thought was a great idea, and it was starting, they were all going to do it this way. And it turned out not to be such a great idea because it didn't work exactly as anticipated. There were unanticipated consequences. There were details that hadn't been thought through. So by going through a testing approach, we can learn, is it going to work exactly as we plan, or do we need to make some adjustments? We've got a variety of different practices just even represented on the session here today. Some of you may be in large practices. I know some are based on hospitals. So how a change works in your setting might not be exactly the same as how it works, for example, Cindy, in your setting or for somebody else. So testing it helps us do a few different things. When we have an idea, know if it's going to lead to improvement. So if we test it, we can increase our belief in that. We can increase our confidence in the idea. How much improvement there's going to be from the change. And if I could just ask sidebar here, if folks could mute themselves when not. Super helpful. So it keeps the background noise out of the recording. Thank you. It also helps us learn how we have to adapt it. So if it works in one setting, but might need some tweaking in our setting, then doing a test helps us figure that out quickly and without a lot of consequences. And it also helps us minimize resistance. If some people aren't crazy about the change idea, they can see other people trying it and realize, oh gosh, you know what? It's not so bad. Or maybe, wow, it really is a better way of doing things. No, it does the same thing to me. This is what happened last time. So Jake, if you could please pull up the PDSA cycle slide, we'll try again. If that doesn't work, I'll just have you advance for me. So most of you are probably already familiar with the PDSA cycle, and this is a methodology that is very similar to what you do in an experiment, where you make a hypothesis about whether or not something is going to work. You make some predictions, you ask some questions about what do we want to learn by trying this out. It's actually how we learn to do everything, including how we learn to walk. If you watch a little toddler trying to learn how to walk, they're actually doing PDSA cycles over and over again because they plan what they're going to do, grab a piece of furniture perhaps, pull themselves up, give it a try. Of course, we know what happens, they fall, and then they think about it, and then they try something different. If you were going to learn how to play golf or learn how to play a musical instrument, you would have to go through a series of things. You wouldn't be able to go out on the golf course and hit all hole-in-ones the first time out, or sit down at the piano for the first time and play a concerto. So we have to learn, and testing helps us learn without having a lot of consequences. So the PDSA cycle, also known by the other names you see in the lower left, gives us a structure for doing that. So first we make a plan. What is it we want to test out? What do we think is going to happen? What could happen if it goes differently than we expect? What do we want to learn by doing this? Then we go out and we do it. Then we study what happened, preferably immediately. And then in the act phase, we think about, okay, so now what are we going to do based on what happened? Are we going to test this again, perhaps with a few more people for another couple of days? Do we have enough knowledge to say, yes, we're really confident that this change is a good idea, let's make it a permanent part of the way we do our work? In the PDSA cycle, you'll notice each portion of the cycle is the same size because they're all equally important. Now, that doesn't mean they take the same amount of time. Doing the test might take a minute. It depends on what it is you're testing and how broadly you're testing it. But each phase is really afterwards. No, we're just going to do it this way now. That can lead to a lot of unintended results. So planning it, carrying it out, studying it, and then deciding what to do next. Not going to let me advance the slides. Oh, maybe it will. Okay, that worked. So some strategies for successful tests. One is start small, and I mean really, really small. I like to use what I call a rule of one. One nurse, one patient, one physician, one time, one shift, one day. And I'll give you an example in just a moment of how you can do some of this on a small scale. If you try something with one person, let's say you see a standard order that another practice is using and you think, we'd like to try that in our practice, see if we can improve our flu vaccination rates. Try it with the first patient of the day and see if it works. And then have a little quick huddle. How did it work? Did we like it? Is the format workable? Did the wording feel comfortable? What might we change, if anything? Just trying it one time will give you some ideas. It also gives everybody on the team, including the staff, the opportunity to say, I like it, but it might work better if we did this. And then you can say, great, let's try that with the next patient. And that way you're learning quickly. Sometimes fear testing because they think it's going to slow them down. And they say, I've got way too much to do. I don't have this time for this testing stuff. Just give me the change and we're going to do it. But actually testing, if it's done on a small scale, can be done very rapidly and doesn't slow you down and yields a ton of learning. So think about testing things on a really small scale and then building up. So if you test it with one patient, seems to work really well. Test it with a few more, seems to be going well. Say, okay, let's try it with all patients tomorrow. And if that works well, let's do it for a couple more days and make sure that you try it over different conditions. You want to start with the willing. So if people are resistant to the idea of the change, don't use the test to try to convert them because it usually doesn't play out very well. Use the people who are saying, yeah, I'm willing to give it a shot. Most people, if you ask them to try something one time and you assure them that if it really doesn't work, you won't make them do it again, are willing to do it. And then it's really critical to listen to their feedback. If you do that, it might make the next test even better. Simulation is a good way to do it, especially if you don't want to disrupt the workflow in your practice or you don't want to adversely affect patient care, of course, you don't want. So you could simulate it. You could do that with standing order. You could say, okay, well, just take a copy of it with you. And as you see the patient, go through, if you used this, how would it fit into the workflow? You think it would work, and then get feedback. That's a kind of a test. If you have different shifts, depending on how the structure of your practice is, so if you've got hours where different staff work, make sure you test it all. In hospitals, for example, we've learned that you can't test things only on Monday to Friday on the day shift because we've got to think about the weekend staff and the night staff and the people who are only there on holiday. So we want to make sure we think about all of the different participants in the process. And then think a couple of cycles ahead. If you plan a test and think about, well, if it works, what will we do next? Think about that as part of your plan. That way, if it goes well, and you think that went really well, let's test it a little bit more, you already know what you're going to do. More patients, more staff, more days, whatever that might be. So measurement and data collection. Here's feared by some people because they think, oh my gosh, this is going to be so much work. We're not collecting data to submit to the New England Journal of Medicine. So we don't need randomized, double-blind, controlled, sophisticated data. We need just enough data to learn how's it going. So in a PDSA cycle, you want to collect just enough data to learn, did that go well? Is there something we should do differently? Are there pieces of it that don't really seem to fit here? Does the whole thing not? So using just enough data, and it doesn't have to be perfect data, because again, this is not research data, it's not data for evaluation, it's just to learn, do we want to test it further? Do we want to think about making this part of the way we do our work? Pencil and paper is fine, it's often recommended, because modifying information systems is tedious and complicated and take a long time, and when you're dealing with like a vendor for an EMR, sometimes impossible. They might just come back to you and say, yeah, thank you for that feedback, we'll consider it for our next release. So you don't have to worry about building it into the EMR at the testing phase because you don't yet know whether or not the change is going to work. So think about using simple pencil and paper to get a little bit of data. Sampling, you don't have to collect it for every patient for every day. Sometimes just a small portion will give you what you need. Quantitative data is super important, not just the quantitative data. I remember once when I was working in the hospital and we were trying to improve the outpatient registration process, and we tested something that was faster, but the registrars hated it. So from a quantitative perspective, it was more efficient, but from a qualitative perspective, they didn't like it, and we would have been foolish to roll it out because they would have just made it not work. It's not worth sacrificing staff satisfaction to get something more quickly. And make sure you capture things that happened that were unexpected. If somebody says, gosh, I never actually thought that would happen when we tested this, do that, learn from it, because it can be really useful. So sometimes you just need a little bit of simple data to give you a lot of information. So we came up with a little collection form, and a copy of this form will be on Simple QI. Here's something that you could do actually next week. If you want to learn a little bit more about what's happening with influenza vaccines in your practice. So think about doing this one day next week just for 10 patients. You can do it for the whole day if you want to, but I don't think you'll learn a whole lot more if you do the whole day than you'll learn if you just look at the first 10 patients of the day, for example. This little form, and if you select a day next week, and you can do just a portion of the day, the morning, you can do the afternoon, whenever you get to 10, you can stop. But put down the name of or some other identifier for each patient. This is for you, not to be sent to us. Please don't load it onto Simple QI because we don't want patient identifiable data, as we said before. But as the patient is leaving, when they get discharged, somebody, whether it's the person at your reception desk or an MA or somebody else, put down something for the patient and then put a check in one of these three columns. Their influenza vaccine is noted as having been received, whether it's at your place or someplace else, maybe they got it before they came, that they've refused it or they have an allergy or some other exemption, or nothing is documented. No idea what their flu vaccine status for this season is. Things that you're collecting the data. And then at the end, team get together, to be everybody who works on this in the practice, and talk about, well, what did we learn? Were there any surprises? Why do we think that people may have refused, if we have any who refused? If we don't have documentation, why do we think that is? What are some ideas for things we might do differently to ensure that for every patient, we have a check mark in column 2, and that we have nobody with no documentation? And then whatever change idea you come up with, think about using a PDSA cycle to test it out, and then repeat. You could do this again. You could do a change, and then the following week, you could say, all right, let's do this on 10 more patients and see, are we still in the same place, or are we doing a little bit better? So the form will be on Simple QI, along with some of the questions that you might discuss as a team. Following. It would be really interesting to learn from anyone who tests this, how it works out. So as we think about tomorrow's session, because tomorrow we have a QI session, and we hope that these will flow. So some of you will be on tomorrow's session as well. Some of you, your staff, may be joining us tomorrow. So what we'd ask you to do between today and tomorrow is do one of two things. So in the baseline data, we asked you for breakdowns by racial and ethnic groups, which some of you have been able to collect and some not. If you've been able to get that data, take a look and see if there's any group with a disparity, which would be more than 10% difference from whatever group has the highest percentage on a vaccine. And talk about why is it that you think you've got a disparity with that particular group? What are some other things that you might do in order to address that disparity? If you're having trouble getting that data, or if you think the data that's coming out of your EMR isn't particularly useful, it may not be accurate, or there's far where it's just unknown, then discuss as a team, what are the barriers that you may be entering to capturing that information in your EMR? Are they barriers in getting it from the patients, or are there barriers in getting it into the EMR? Whatever those might be. And we would ask every practice coming to tomorrow's session to be ready at the start of the call to share a little bit about what you learned from this discussion. So you just might need 10 minutes at the end of the day to have this discussion. And then tomorrow, what we'll be talking about on the QI session is strategies to capture more information on race and ethnicity, getting it into the EMR so that you can really leverage it to understand where the differences might be within the patients within your practice. So I will stop there and turn it back over. I'm not sure whether that goes back to Jake or Cindy.
I think that's it.
We should still have the follow-up question.
So I have just launched the polling for the exact same question that we asked earlier. Please ask. We will leave this open for about 45 seconds.
And while you're filling that, think of any questions that you might have of anything that we discussed for today. Okay.
All right. Dr. Barty, you're able to see the results right now?
Yep. And so, particularly if you look at the steps to better influenza vaccination rates, all of these are listed among that, not that there's a right or a wrong. And so maybe looking at, are there things in your office along those lines that you could focus on to try to make some clinical changes, and could that be part of a PDSA cycle? Any other questions that anybody has? Okay. Thank you very much. And I think Fran will be with the folks that are on tomorrow looking a little bit more at some of the data.
All right. Well, that's it for today, everybody. Thank you all very much for attending. We will be uploading today's recording to our YouTube page, and any of the resources that were provided in today's presentation will be sent to you along with the evaluation. Thank you very much, and please enjoy the rest of your day.
Thank you.